Good afternoon or good evening, ladies and gentlemen. I'm Ki-Chul Sung from Seongkyungwan University Gangbok Samsung Hospital. I will chair this webinar with actually Dr. Jigang Wang from Shanghai, but he's not here, so I will chair this session honorably. And the session title is How to Apply Theory to Clinical Practice. And we have two speakers, two excellent and two famous speakers. And I'd like to introduce the first speaker. Is Dr. Jeong Bae Park. He's the current president of Pulse of Asia and professor of Yonsei University Wonju College. And he will talk for arteriosclerosis and atherosclerosis in clinic. Dr. Park, would you start?
Thank you very much for your introduction. Can you see my slides?
Yes.
Okay, I will start. It's a very pleased to introduce some of my talk on the atherosclerosis and arteriosclerosis clinic. Maybe this is, I think it is good topic for these times. A famous saying of Thomas Sydenham states, man is as old as his arteries. However, changes in the function and structure of arteries with aging, such as arterial stiffening and thickening, do not occur to the same extent in all people. So today's topic is how old your arteries. Is it useful to understand, apply in clinic? Two key vascular changes according to aging and cardiovascular risk, such as hypertension, hypercholesterol, bulimia, and diabetes are first atherosclerosis, and then second is arteriosclerosis, meaning the arterial stiffening. When heart pumps, two main hemodynamic changes occur due to one is flow, the other is pulse. Pulse is much faster than the speed of flow. Strong resistance of small arteries, such as resistance artery, due to small artery inward remodeling is the earliest finding of high blood pressure and probably the aging. The term of atherosclerosis in this topic is often misused with atherosclerosis, but here in my talk, arteriosclerosis means that arteries become thick and stiff, meaning the hardening. In contrast, atherosclerosis is one of arteriosclerosis type, an inflammatory condition to intimal injury, and so a fatty waxy buildup in arteries named as plaque, which leads clogged arteries and reduced blood pressure. Are there any evidence of vascular changes leading to cardiovascular events independently with other traditional cardiovascular risk? In about 20 years ago, we first found that structural alteration of resistance arteries were demonstrated in most hypertensive patients, followed by endothelial dysfunction and cardiac hypertrophy in a small number of hypertensives. Small artery structural and functional structural remodeling may precede most clinically relevant manifestations of target organ damage in mild essential hypertension. These findings were found independent to blood pressure in patients with high blood pressure and the hypertension treatment. Blood pressure and the structural and functional abnormalities are commonly found, but there are a big difference on these changes depending on antihypertensive medications, irrespective of blood pressure reduction, so-called beyond the BP reduction effect. Later, this difference of vascular changes resulted in different outcomes despite of the same blood pressure reduction in hypertensive patients, which means vascular, structural, and functional changes should be understood in managing hypertensive patients. So, sorry. So this later this difference of vascular changes result in different outcomes despite the same blood pressure reduction in hypertensive patients, which means vascular and functional changes should be understood in managing hypertensive patients. The other big study to demonstrate the differential impact of blood pressure lowering drugs on central arterial pressure, a useful marker of arterial stiffening to influence clinical outcomes. And so a primary object is that the two different blood pressure lowering regimens in ESCOT studies would produce different effects on central aortic pressure and hemodynamic despite the similar blood pressure on brachial blood pressure. Here you can see one of the two different drug combinations showed a significant difference in central blood pressure, aortic systolic blood pressure through 6 years study period, despite the similar systolic brachial systolic blood pressure reductions. These results favor that the effects of central systolic blood pressure, meaning vascular stiffening, show the significant different outcomes of fatal and non-fatal stroke. Personally, we have enough evidence on the beneficial effects on our reversing atherosclerosis and arteriosclerosis, but still guidelines are mostly focusing cardiovascular risk disease such as hypertension and diabetes and hypercholesterolemia. I think this is the right time to discuss how to utilize atherosclerosis and arteriosclerosis in the clinic. About the measurement of the atherosclerosis and arteriosclerosis. This is a technique to measure atherosclerosis and arteriosclerosis. In clinical, left is atherosclerosis, right is arteriosclerosis. Some of these techniques are commonly used in my talk today. On atherosclerosis, I'm going to talk about the carotid arteries, plaque, and intermediate thickness. For arteriosclerosis, I'm more focusing on pulsatile velocities. This is a good example of measurement of atherosclerosis in carotid arteries, intermediate thickness, and the plaque. This slide shows an example of arterial stiffening, 3 major measurements of pulsatile velocity. Carotid femoral pulsatile velocity, this is the gold standard, but this is not commonly used in Korea and other Asian countries. On the right side, BAPWB, brachial ankle pulsatile velocity, and cardio ankle pulsatile velocity are more commonly used in Asian countries. So I will focus more on the KV measurement, KV techniques to explain the arteriosclerosis. This is in the KV vascular index. KV is an index of overall stiffness of artery from the origin of aorta to the ankle. KV, interestingly, KV is less affected by blood pressure at the time of measurement than the gold standard method, carotid femoral pulsatile velocity. How to evaluate vascular aging in clinic? Is it real? This slide shows arterial changes according to aging, showing the difference between the atherosclerosis and arteriosclerosis. On the left side, atherosclerosis, this is an inflammatory condition to endocellular injury. Mostly it affects endocellular cells intima, and any injury to endocellular layer induces endothelial dysfunction and later buildup of plaque. In contrast, in arteriosclerosis, this is a problem of collagen elastin deteriorate and increased vascular smooth muscle cell stiffness and the numbers. My colleague and I developed differently measuring the method of carotid arterial walls, intima, and the media, and the intima media thickness using echo trackings. What our research group found is that aging is key determinant of changes to individual arterial wall layer for high-risk patients. Look at these slides. Look at these slides carefully. The changes of intima media thickness progression with age is mostly progression of media thickness rather than the intima thickness. This is true in both the male and the female. The second topic of our research is that what is high cardiac carotid intermediate thickness value. In this study, we used 75% for the high carotid intermediate thickness for increased cardiovascular risk. In about 50 years of ages, 75 percentile value is about 0.715 for male, 0.719 for female. This is similar to the international reference values about the middle of ages about 40 to 50, clinical between the 7.75, 7.7, 0. And 0.5, sorry, 0.7 and 0.75 millimeter and higher in middle age is considered to as high for cardiovascular risk. So in our data, the predictors of total cardiovascular side effect is that the CIMT is hazard ratio is 1.512 and the carotid plaque is 1.991, which is similar or higher to the risk of diabetes and the lower ejection fractions. So the second part is the progression of atherosclerosis, the KVRWG data according to ages. Both men and women show a substantial increase of KVRWG according to ages. But look at this one. On the right of the figure, the progression of KVRWG is more strongly associated towards progression of systolic blood pressure and diastolic blood pressure. This may mean that the KVRWG is more useful tool than systolic blood pressure or pulse pressure in clinic to measure arterial aging changes. What is real in clinic? The EVA, normal, supernova. Many physicians in Western society introduced the idea of early vascular aging EVA and supernormal vascular aging supernova. To measure vascular aging, they developed the best fitting model for age prediction based on cardiovascular risk factors and treatment and pulse velocity here. And the delta age difference is that the chronologic minus vascular aging. And the EVA is negative data, negative delta ages, and the supernova is a positive delta wave agent. It means a more lower rate of cardiovascular events. The EVA is early vascular aging, means higher rate of cardiovascular events. So they found the cumulative instance for cardiovascular events in the Malmo diet and cancer cohort study about in more than 2,600 people according to classification into EVA, normal, and supernova. Hazard ratio of EVA is 2.7 and the supernova is 0.95 for almost 9 years, the follow study period. My friend, the Thomas Weber introduced an idea on how transform the concept of vascular aging into clinical practice. His idea is adding pulse velocity, a tool for vascular aging. He can clarify the EVA and supernova. Maybe it is very useful to risk stratifications, maybe the guideline or treatment thresholds. What is in the real situation in clinic? The Hao-min Cheng, a next speaker from Taiwan, conducted a nice study on fast assessment of atherosclerosis and atherosclerosis at a point of care in cardiovascular outcome clinic. Using the pulse velocity, he modified the treatment, and which results in better blood pressure reduction, systolic blood pressure 11 millimeter mercury, and the BA-PWB 0.2 millimeter per second, the reduction by up titration of reduction. In contrast, there is in a group of no changes reduction, there was no change of blood pressure and BA-PWB and the ankle brachial indexes. This slide shows they have blood pressure, high blood pressure and hypercholesterolemia, the well controlled and blood pressure and the cholesterol and diabetes. They have a significantly higher, there is a higher pulse velocity in 57-year-old female and a 49-year female patients. She came to our clinic with chest pain. She had a recent COVID-19 infection, hypertension, hypercholesterol, hypothyroidism, reaction, blood pressure, and cholesterol. The diabetes were well controlled, but she has a proteinuria, and her creatinine is 1.85 higher, and the eGFR was 35. And in the character study, she had a focal soft plaque above the ECM maximum 1.44. It makes you smaller atherosclerosis, but a very higher level of KV index 9.2. Usually the threshold higher means 9 point. The third case is the 47-year female, recent hypertension hypercholesteremia. She has a lupus nephritis at 20 years. Now she is completely resolved, but still she had some high pressure and some higher KV levels, even though the capillary artery is normal. So in my last slide on the next action at clinic, maybe the pulse velocity is a good surrogate marker of cardiovascular risk, and we can define the vascular aging versus chronology aging, maybe early or supernormal vascular aging. Maybe we can use these. If you use these tools satisfactorily, maybe we can re-stratification of risk about the 13 points higher for cardiovascular risk for intermediate groups, and using arterial phenotype, maybe integrate the insensitive risk factors. Maybe we can also found residual arterial risk in addition to conventional cardiovascular risk like inflammatory changes, connective tissue diseases, and the renal functions. And we also need the follow-up studies, at the clinic after intervention and pharmacologic or non-pharmacological studies. Maybe I want to discuss on how clinical use of vascular aging in clinic and some limitations of clinical use of atherosclerosis and atherosclerosis. Thank you very much for your listening.
Okay, thank you, Dr. Park. Actually, we have no question from audience. And Dr. Cheng, do you have any question or comments for Dr. Park's lecture?
Yeah, thanks for the excellent speech. And so can you share with us how do you integrate the atherosclerosis and arterial stiffness into the calculation of the vascular agent, such as the EVA and supernova? So as you mentioned that Professor Meyer proposed the concept. So usually we will use only arterial stiffness to define the vascular agent. Yeah, so how do we use intermediate thickness or some other measure?
No, yesterday I talked with Thomas Weber, and you really use the vascular aging in your clinic. So there was a small group of vascular net. I'm not sure the exact name, but even small number of people in the clinic use the vascular aging actually apply in the clinic. So they recommend, Thomas recommended the 90% of pulsatile cutoff value of in general population, maybe the useful cutoff value. If you're higher than the 90% percentile of pulse velocity, mostly they use corrected femoral pulse velocity, and over the 90 percentile, maybe which means the EVA early vascular aging. So maybe you can use these techniques based on your people's data. Maybe the Western and the Eastern study may be different on the progression of the pulse velocity. So if you have more than 90%, maybe the patients may show the early vascular aging.
Yeah. So do you think we should also incorporate the intima thickness into that equation?
Intima thickness, maybe one of my colleagues developed these tools. They different the intima and the media and the intima media thickness. But actually, in hypertensive patients, usually the media thickness is more important than the intima thickness. In case we have to have a tool to measure separately between intima and media. So maybe if you can use if you can use these techniques, maybe what is meaning of a higher intima media thickness? Because usually most of the aging and high blood pressure means the media thickness rather than the intima thickness. Usually, from the media intima to into the lumen, the bulging of intima, this is mostly due to atherosclerosis, like inflammatory condition, the intimal injury. But if you find the media thickness, this is mostly due to the hypertension aging. So if you want to see the changes in hypertensive patients, you have to more focusing on the media thickness rather than intima thickness. But if you want to see changes in diabetes, other the metabolic diseases, maybe intima thickness is more favorable the measurement tool for compared to media thickness measurement.
Yeah, thank you.
Okay, no more question. I have one. Yeah. Alberto Abolio have one question. Since BAPWV is easier than CFPWV, is it used widely in the clinic setting in Asia, Dr.
I haven't seen many physicians using carotid femoral pulsatile velocity because usually the company, maybe this is company dependent. In Korea, I'm not sure that Taiwan is also the same the situation. The Fudadensi and the Omlon company introduced their devices in Korea. So BAPWV from the Omlon and the KVRWG from Fudadensi are widely spread in clinic in Korea. So that's why BAPWV and KVRWG is more popular than the measurement of the carotid femoral PWV. So maybe the comply the measurement or the Australian instrument are not popular in Korea. That's why BAPW and KVRWG is more popular than the older standard of CFPWB.
Okay, thank you, Dr. Park. No more question and comment. So now we have to move to second topic. And second speaker is Dr. Hao-min Cheng from National Yangmin University, Taiwan. His title is Excessive Pulsatile Energy in Carotid Artery is associated with reduced cognitive function, pulsatile and steady-state arterial hemodynamics. Dr. Cheng, please, will you start?
Yeah, thank you. Can you hear and can you see my slide?
Okay, I see. I can see.
Okay, thank you. And ladies and gentlemen, it's my pleasure to share with you in this POA webinar how to apply theory into clinical practice. And this is the presentation outline today. I will like to present two cases of EVA and supernova. In the following part, I will let you know the importance of pulsatile hemodynamics in the process of identifying subject with EVA and supernova. The last part is the focus of the presentation today, the influence of excessive pulsatile energy in carotid artery on cognitive functions. Yeah, so the first is what is EVA and supernova? As introduced by Professor Park earlier, they are vascular agent phenotypes. We can calculate the so-called delta age, which is the chronological age subtracted by vascular age. And the younger vascular age compared to the real chronological age is more likely to be the supernormal vascular agent. So the usually is positive. On the contrary, the older the vascular age, it would be the negative delta age is more likely to be the EVA, early vascular agent. By definition, the top and the bottom 10% of subjects are the EVA and supernova. So the first case is the supernova case. This is a 76-year-old woman with vascular age 64 years old. Then the delta age is positive 12. You can see she had a normal BMI, normal blood pressure, and the carotid femoral pulsatile velocity was around 8 millimeter per second. She also had no hypertension history, but only the dyslipidemia on the lipid-lowering drugs, and she had a normal cognitive function. As you can see in the right panel, you can observe the old woman had a normal pulse pressure. The pulse pressure is around only 35, and also the normal, relatively small carotid flow amplitude. And here we briefly introduce some novel hemodynamic analysis we just developed. After we measure aortic and the carotid pressure and the flow, then we can come up with the power of the aorta and the carotid artery. Then by integrating the power in the with time, we can calculate the total mean and pulsatile energy. And this is the energy that we can obtain. We can obtain from the pressure and flow waveforms. In the past, we can use only the pressure and flow to evaluate the influence of circulatory artery wave on vital organs. However, it is energy that provides the real effects on the body systems. And therefore, we derive the power and the energy by pressure and flow waveforms. Power is the product of the pressure and flow. By integrating the power over time, you can derive the energy. So we can derive the total energy, mean energy, and also the pulsatile energy. So the difference between this, the total energy and the other two components is the potential energy. As you can see in this supernova case, you can observe lower than the peak shoulder in the carotid power and a very small carotid pulsatile energy. The carotid energy PI is only 0.06. In the second case is an EVA case. This is a 73-year-old woman with vascular age 83-year-old, but so the delta age is minus 9.9 years. This EVA case, you can see she had a high BMI, isolated systolic hypertension, increased pulse velocity. Besides, she had hypertension and dyslipidemia also on treatment. To notice, she had a lower than normal MOCA score. In the right side panel, you can observe that the old woman had a high pulse pressure, and also high carotid flow amplitude. And for the this EVA case, you can observe the increased less systolic peak in the carotid power, the carotid energy, and the pulsatile energy, PI, pulsatility index, is higher than the supernova case. So you can observe the pulsatility index for the carotid energy is 0.08. There are different aspects we can observe in the arterial hemodynamics, including the steady flow and the pulsatile hemodynamics. For steady flow, we can use the mean blood pressure to describe the arterial pressure, which is determined by the cardiac output and the total peripheral resistance. But as you know, arterial pulse wave is generated by left ventricle during the transmission to artery, pass into the systole, and the large artery expands to store some energy so that the blood flow may continue during diastole. This property of arterial compliance is very similar to the Wien-Castle chamber. So we can describe the waveforms through the equations here using the stroke volume and the RT impedance. We can calculate the pulse pressure. So the waveform shapes and the pulse pressure is determined by the aortic impedance and stroke volume. Ideally, our pulse wave should be similar to the surface wave as shown in this figure. However, in subject with vascular aging, with the presentation of arterial hypertension and increased pulsatility, and heavily wave within arterial systems could be observed. the human's arterial system in the young is beautifully designed for its role of receiving the spurts of the blood from the left ventricle and distributing this as a steady flow through the peripheral capillaries. Central to such design is tuning of the heart to the arterial tree, and this minimizes the arterial aortic pressure fluctuations and confines the flow pulsations to large artery and into the small arterioles. And with aging, the repeated pulsations, some over 30 million per year, cause the fatigue and fractures of elastin lamina of central arteries, causing them to stiffen and to dilate, so that the reflection return earlier to the heart. In consequence, aortic systolic pressure rises, and the diastolic pressure falls, and the pulsation of the flow extends further into the small vessels of vasodilating organs, such as the brain and kidney. So the stiffen lead to the increased left ventricular load with hypertrophy, decrease the capacity of myocardial perfusion, increase the stress on the small arterial vessels, particularly of the brain and kidney. So that will cause damage to the vital organs. So the next question is, how do we identify subjects with EVA and supernova? And you have seen this slide before in Professor Park's lecture. As illustrated in this figure, with increased age, subjects with EVA could have accelerated arterial stiffening and cause higher risk of target organ damage than subjects with AVA, average vascular aging, and the supernormal vascular aging. So how do we estimate the vascular age? There are several approaches to estimate the vascular age. You can simply use the carotid femoral pathway velocity, or we can use the age and the blood pressure stratified carotid femoral pathway velocity to categorize the level of vascular age. Or we can combine the carotid femoral pathway velocity, CV risk factors, and treatments into the consideration of vascular age. So in the paper just introduced in Professor Park's lecture, this study used the definition and validation cohort. So in the definition cohort, they construct the regression equations with the pathway velocity, CV risk factors, and treatments as the independent variable, and age as a dependent variable. So then you can calculate the vascular age, and by the equations shown here, you can calculate the delta age. So in this cohort, the EVA group had a high risk of CV events. So the main focus of today's talk is about the cognitive decline. So what's the relationship between the vascular aging and dementia? Dementia and cognitive decline have become a major health care concern, especially in aging populations around the world. And there have been many risk factors implicated in the pathophysiology of cognitive decline. Among them, vascular aging and arterial stiffness have been proposed as important risk factors contributing to dementia. So central hemodynamics plays a key role to understand the brain damage in hypertension patients, because arterial stiffening is a major determinant of elevated central blood pressure, and higher central pulsatility is a mechanical factor for brain tissue damage. It has been shown that both increased arterial stiffness and central blood pressure are predicted of stroke. And previous studies also show that the mechanics and remodeling of intracranial large arteries, the common carotid arteries, are representative of wall damage and intracranial large arteries. However, whether the antihypertensive treatment target at reducing arterial stiffness or central blood pressure better prevent stroke, while mental regions and cognitive decline remains to be determined. So how does the arterial stiffness and associate with the microvascular disease in the brain? It's been suggested that the early vascular aging could increase the carotid pressure and flow positivity due to the phenomenon called impedance mismatch. And then it can cause microvascular damage and impair the vasomotor reactivity and further the microvascular and tissue damage. A strong body of evidence supports the association of vascular dementia and Alzheimer's disease with hemodynamic abnormalities. It's been shown that people developing high blood pressure in the middle life have a greater likelihood of developing vascular dementia and cognitive decline in the later life. And this figure describes very clearly the distinct difference between the carotid and aortic flow in the upper and lower panels respectively. For carotid flow, it is characterized by the low positivity and high impedance. For the aortic flow, we can notice the high positivity and low impedance. In our previous studies, we have shown that the blood pressure and the carotid flow velocity associated with brain falling and cerebral small vessel disease in cross-sectional study design. More specifically, high blood pressure and the lower carotid flow velocity were associated with a high risk of cerebral small vessel disease. And furthermore, in a prospective study, we have shown that the carotid flow positivity index combined with central blood pressure were positively associated with stroke incidence. In each stratum of central SBP, higher carotid flow positivity was associated with a higher incidence of stroke. And now we will introduce a complex concept called impedance mismatch. At a young age, the aorta is very elastic with low aortic impedance, and the carotid artery had a small diameter and a high vascular impedance. Therefore, the impedance mismatch is a natural barrier that will block the excessive pulsatile path to damage the brain. But as we get older, the aorta becomes stiffened, so the mismatch becomes matching. So the loss of the natural barrier makes the pulse wave can easily enter to the brain and cause damage. And through comprehensive analysis, we will investigate such a hypothesis. And this is the recent study we just finished in submission. We investigate the role of carotid pulsatile hemodynamics in our two ongoing cohorts, the CVD FACS and the last cohort, and with a total around 1,800 patients for this analysis. So we also obtained a comprehensive hemodynamic measurement through the acquisition of arterial pressure and flow waveforms. The most important of these parameters include carotid ferron pulse wave velocity, the characteristic impedance. It is the proximal aorta stiffness. And then we can also calculate the forward and backward wave and also the systemic vascular resistance. And this is the distribution of these subjects, the pressure, flow, and also the energy at the ascending aorta and the carotid artery. The mean pressure in the ascending aorta is 93, and the pulsatile pressure is 38, so it's around 3 to 1. The mean flow in the ascending aorta is 82, and the in carotid artery is 23, so it's around 1/4, 25%. And the pulsatile flow is around 317, and in carotid artery is 31, so it's around 1 to 10. And that mean in the mean energy in the ascending aorta is around 900 millijoule, and in carotid artery is 270, so it's around 25% as well. But for the pulsatile energy, you can notice in this table, in the ascending aorta is around 100 millijoule, but in carotid artery is only 10. So it's only 1 to 10. It's 10% only 10% of the pulsatile energy. So we did the correlation analysis of these parameters with the cognitive function, the MoCA. So you can observe the aortic pressure positivity index, aortic pulsatile energy, aortic energy positivity index, carotid flow positivity index, or were negatively associated with MoCA, but carotid mean energy was positively associated with MoCA. Moreover, the proximal aortic stiffness, the ZC, or the aortic characteristic impedance, and the aortic energy transmission coefficient were negatively associated with MoCA. So it suggests the phenomenon of impedance mismatch become match. Then we further found that the carotid energy positivity index had the highest correlation coefficient with MoCA among all positivity index, better than pressure, better than the flow. So it's energy that causes damage. So we further control the potential confounders, including age, sex, education, depression score, heart rate, and sugar. And we found the carotid energy positivity index was also remains significantly associated with MoCA score. And the carotid energy positivity index is determined by the mean energy and pulsatile energy. And you can see the opposite association with the MoCA. So the mean energy is positively associated with MoCA, but pulsatile energy was negatively associated with MoCA. So in subject classified by the quartile of the aortic carotid impedance, it's the proximal aorta stiffness. With the increasing proximal aorta stiffness, you can observe the increased aortic forward wave energy transmitted into carotid artery, and the carotid pulsatile energy, and also the carotid energy positivity index. So the stiffen of the proximal aorta will cause the more energy transmitted in the pulsatile form into the brain. So this phenomenon can be better illustrated in this figure. And as you can see, with increased LT wave pressure reflection coefficients, there is a decrease of the carotid energy positivity index. It means that if in the young, there is a higher reflection coefficient, so the carotid energy positivity index will is reduced. So this is the impedance mismatch phenomenon. So we would like to comprehend the determinants of the carotid mean pulsatile and the carotid energy positivity index of their determinants. It was shown that the major determinants of the carotid energy PI were the aortic mean energy, aortic pulsatile energy, and the aortic characteristic impedance. So the similar determinants were noted for the carotid pulsatile energy. And for the carotid mean energy, you can observe the opposite association compared with the pulsatile energy. So, ladies and gentlemen, in conclusion, we can estimate vascular age, identify delta age and the corresponding EVA and supernova subjects, and the increased carotid pulsatile energy and the reduced carotid mean energy summarized as the increased carotid energy PI are detrimental to cognitive function. The higher proximal aortic stiffness and the resultant eroded aortic impedance mismatch is associated with the excessive pulsatile energy across the aortic carotid, the interface into the carotid artery, resulting in the higher carotid energy PI that has the strongest association with the lower cognitive scores. In the measurement of the arterial flow and pressure can help us understand the pulsatile hemodynamics and its impact on vital organs. So thanks for your attention.
Okay. Okay, thank you, Dr. Cheng. Dr. Park, can you hear me?
Yeah, of course.
Do you have any question or comments for Dr. Cheng's lecture?
Okay, thank you. It's a very nice presentation, very wonderful. I'm really interested in your the idea on the EVA and the carotid energies they may be implicated in prediction of the cognitive functions. But one simple question: how does it need to measure the carotid hemodynamics here in a person?
Yeah, in our clinical practice, we are developing some better tools to more quickly obtain the flow. Because if you want to integrate the pressure and flow into the calculations, you must have a easier tool. Now we use the Doppler to obtain the flow, and the tonometer to obtain the pressure. That will be a very complex process. So in some cases, we will arrange such a kind of examinations for the patients, and we will use all these standardized tool to obtain the hemodynamics. But in the future, if we want to calculate the power or energy in the clinical practice, we need a more user-friendly tool. So now it's in the process of development.
So do you use a pressure at the carotid arteries, or you use the brachial artery pressure when you calculate the carotid power?
Yeah, we use the carotid carotid pressure waveforms as the surrogate of artery pressure, because they are very similar.
So do you think it can be applied to the other arteries like the aorta? Maybe if you want to some of the changes of the aortic diameters, like in ascending aorta, maybe the idea in the carotid artery can also apply to aorta. So if you use the techniques, maybe you can estimate these 5 centimeter diameter. Maybe you can have a high risk of the rupture or dissections. Maybe the idea can apply to your in aorta artery or abdominal aorta. Is it possible?
Yeah. We routinely measure the LT diameter, so it's a very interesting speculation that we would like to see whether the energy will cause the expansion of the LT diameter. So that's a very interesting future direction. Yeah.
My last questions about the Dr. Bruno's study on EVA and the supernova. So that study, they have only higher the very old age people, about more than 60 years in average. So maybe the same idea can be applied to young people less than 60 or 40. And the second one is they would be racial differences. Maybe the idea from the study done in Western society can be the same in the Asian people, because usually the progression of the arterial stiffness would be different from between the Western and the Eastern societies. So the idea can be true in Asian countries.
Yeah. I think there's the racial difference. So yeah, it's very interesting to see, like Professor Volia in the study in China, that there's a very stiff progression with age of the arterial stiffness. So I think yes, we should observe also the change between different races. But in our populations, is all the Chinese population. So we need some collaborations with others to see the changes. Yeah.
Dr. Cheng, we have one question from audience. Is again Dr. Volio, and his question is: impedance value normalized for change in vessel diameter?
Yes, we have calculated the normalized impedance based on the diameter as well. Yeah, and the primary analysis was the raw impedance. So we did both of these measurements. Yeah, so the idea of the normalize is to standardize the impedance with the body size. So I think it's a good suggestion. So probably we need to see more calculations, more analysis on this issue.
Okay, Dr. Cheng, I'd like to congratulate your excellent work. My question is, how did you adjust many other kinds of biological risk factors for cognitive dysfunction, especially SBP could be important? How did you adjust this kind of risk factors?
Yeah, you mean the EVA and supernova, right? the contribution to the vascular agent, to the to the arterial stiffness. I think in previous many studies, the most important determinants are the age and the blood pressure, usually SBP or mean BP. So I think both of these two parameters are very important for vascular agent. And as mentioned earlier in Professor Park's talk, the media change responded to the blood pressure more, and like the sugar and lipid will influence the intima more. So I think for atherosclerosis, the major determinant is probably sugar or lipid. But for arterial stiffening, I think it's the blood pressure and age, that repeated stretch. So that's the I think the fundamental difference between the arterial stiffening and atherosclerosis.
Okay. Anyway, okay. So no more question. Talk about no more comments.
And thank you for your coming here. Thank you.
Thank you.
Okay. I have to wrap up this session. Now we should rest well and rest of the evening, actually well, and hope to see you in person in near future.
Yeah.
Thank you again. See you.
Thank you. See you.
Thank you.
Bye-bye. Thank you.